Hi, my name is Dr. James Ralston. I'm a board-certified dermatologist and started the Dermatology Center of McKinney about 17 years ago. I'm delighted to discuss with you today a topic that's both fascinating and crucial to your future practice as physician assistants: common dermatological disorders. Dermatology is a field that not only deals with the health of the largest organ of the body, the skin, but also often provides clues to systemic diseases. Understanding common dermatological conditions is essential, as you will frequently encounter patients presenting with skin-related issues, whether in primary care, emergency settings, or specialized clinics. Today we will explore various dermatological disorders, their presentations, diagnostic approaches, and treatment options. My goal is to equip you with the knowledge and confidence to recognize and manage these skin conditions effectively. Thank you for your attention, and I look forward to an engaging and informative session. First, we will talk about some pigmentary disorders. Seborrheic keratoses are benign epidermal tumors that originate from keratinocytes. The exact cause is unknown, but genetic factors and aging are implicated. Seborrheic keratoses are more common in older adults, but still happen a lot in people over the age of 30. They tend to run in families, and it's important to note the sudden appearance of multiple lesions may be associated with internal malignancy. It's called the sign of lesser trailotte, or erythroderma. Sign of lesser trailotte may also be associated with skin tags, irritated seborrheic keratoses, tripe palms, and acanthocyst nigricans. Clinical appearance: you'll hear a lot about waxy, stuck-on appearance. Can have a wart-like texture to it, usually brown, but can be different colors, and found on the face, trunk, and extremities. Here's a nice drawing of what seborrheic keratoses look like, along with how it looks under the microscope. Here's a clinical image with a patient with multiple seborrheic keratoses on the back, and a closer view of seborrheic keratoses, and an even closer view showing that stuck-on appearance. These are very superficial lesions. On history, patients may report a gradual increase in the number and size of lesions as they get older. On exam, we expect the characteristic appearance of the lesions we just discussed. Clinical diagnosis is usually sufficient, but it is important to biopsy if diagnosis is uncertain. I've seen melanomas that resemble seborrheic keratoses, so I think it's very important to remember that when in doubt, it is better to do a skin biopsy than to miss a potentially deadly melanoma. Treatment of seborrheic keratoses is not required, as they are benign. However, if they are treated, most commonly treated with cryotherapy, liquid nitrogen. Other treatments involve curettage or electrosurgery or even laser therapy. Generally, no follow-up is needed unless new lesions develop or existing lesions change. However, I do recommend full-body skin exams at least once a year in all of my adult patients. Now let's talk about nevi, or moles. Nevi are benign proliferations of melanocytes, the cells that produce pigment in the skin. They can be congenital or acquired. The exact cause of nevi is not well understood, but they are believed to result from genetic factors and sun exposure. Risk factors: there's a genetic component, sun exposure, and fair skin. Although not all benign nevi follow this, typically benign nevi have uniformly colored appearance. They're symmetrical, they're round or oval with well-defined borders, and small, less than 6 millimeters in diameter. Here's a patient with multiple benign nevi. This benign nevus, which is the singular for nevi, is a brown maculocentral hyperpigmentation. The bottom image is what it looks like with the dermatoscope, showing a uniform pigment network. This is another type of nevus called an intradermal nevus. It's a light tan, soft, raised papule, and with the dermatoscope, you see this focal globular-like structures with whitish, structureless areas and fine comma vessels. Here's another example of an intradermal nevus. Patients may report the appearance of new moles or changes in existing moles. And on exam, look for the number, size, shape, and color of moles. Often patients have what's called a signature mole, where all of their moles generally resemble one another. Dermoscopic exam is extremely important, in my opinion, to determine between benign and malignant lesions rapidly. So diagnostic tests include dermoscopy and then biopsy if malignancy is suspected. And again, like with seborrheic keratosis, when in doubt, it's very important to do the biopsy, as we do not want to miss any melanomas. Treatment involves regular monitoring for changes, surgical removal if there are signs of malignancy or if the mole is bothersome. And for follow-up, I recommend at least annual skin checks, more frequently if there are risk factors for skin cancer. Patient education is important, talking about self skin exams and sun protection. Now let's talk about the dysplastic nevus syndrome, or familial atypical multiple mole melanoma syndrome, or an older term, the BK mole syndrome. I personally prefer the dysplastic nevus syndrome. It's a hereditary condition characterized by the presence of multiple atypical moles or dysplastic nevi and an increased risk of developing melanoma, which of course, as we discussed, is a serious form of skin cancer. Here are some key points about the syndrome. Dysplastic nevus syndrome often runs in families and is associated with mutations in genes such as CDKN2A, tumor suppressor gene, which is also known as P16, MTS1, and P16 INK4A. This genetic predisposition increases the risk of melanoma. Patients with dysplastic nevi who have at least 2 blood relatives with dysplastic nevi and melanoma have the worst prognosis for the development of melanoma. These individuals may have a 100% lifetime risk of melanoma. An associated increased risk of developing pancreatic carcinoma is present in some families. Some studies have also indicated that ocular melanomas may occur in these patients. So, clinical features: individuals with this syndrome typically have numerous moles, some of which are atypical in appearance. These moles can vary in size, color, and shape, and often have irregular borders. They may appear anywhere on the body, but are commonly found on sun-exposed areas. Since they can occur anywhere, I do recommend full skin exams for these patients with the patient's consent. The skin lesions may also be referred to as atypical nevi, Clark nevi, or nevi with architectural disorder. You can see the atypical nevus on top. There's asymmetry as well as several shades of brown, simulating the clinical features seen in melanoma. The lower image shows multiple atypical nevi on the trunk. And just to reiterate, people with dysplastic nevus syndrome have a significantly higher risk of developing melanoma compared to the general population. This risk is further elevated if there is a family history of melanoma. So again, I recommend regular dermatologic examinations for early detection and management of melanoma. Patients are often advised to undergo routine skin checks at home, self-skin exams, practice sun protection measures, and avoid tanning beds. Dermoscopy and digital mole mapping can be very useful tools for monitoring changes in moles over time. Education on the importance of self-examination and awareness of the ABCDEs, of melanoma, which is asymmetry, border irregularity, color variation, diameter bigger than 6 millimeters, and evolving characteristics, is vital. Patients should be encouraged to report any new or changing moles to their dermatologist promptly. Malignant melanoma arises from melanocytes and is the most dangerous form of skin cancer due to its potential to metastasize. It may suddenly appear without warning, but it also can develop from or near an existing mole. Melanoma can occur literally anywhere on the body, but it is most common on the upper back, torso, lower legs, head, and neck. Etiology, we talked about genetic mutations and also ultraviolet radiation exposure, either from indoor tanning or from natural sunlight. Melanoma rates in the US have been rising rapidly over the past 30 years, doubling from 1982 to 2011. From 2007 to 2016, the melanoma rate decreased by 1.2% per year in individuals younger than 50, while increasing by 2.2% per year among those 50 and older. Caucasians and men older than 50 have an increased risk of developing melanoma compared to the general population. Melanoma is one of the most common forms of cancer in females aged 15 to 29. Melanoma incidence is higher in females than in males in younger age groups, though incidence in younger age groups overall have shown declines in recent years. Melanoma can strike anyone, but there is an increased risk for individuals who have more than 50 moles, large moles or atypical or unusual moles, a blood relative such as parent, sibling, child, aunt, uncle, cousin who's had melanoma, if they have sun-sensitive skin, such as a tendency to sunburn easily, red or blonde hair, or blue or green eyes, a history of excessive sun exposure, including sunburns, or a history of indoor tanning raises the risk. A previous skin cancer diagnosis is also a risk factor. And a history of other cancers, such as breast or thyroid cancer, is a risk factor. New, rapidly growing moles, or moles that change, itch, or bleed, are often early signs of melanoma. These should be examined by a dermatologist promptly. And we mentioned these A, B, C, D, E findings. Let's talk about them in more detail. A is for asymmetry, where one half of the lesion is unlike the other half. B is border irregularity. The lesion has an irregular, scalloped, or poorly defined border. C is for color. If the lesion has varying colors within it, or if it is very dark, or if it has areas of white, red, or blue. D is for diameter bigger than a pencil eraser, or about 6 millimeters. However, melanomas can be smaller. E is for evolving. So if the lesion changes in size or shape or color, or if it starts to itch or hurt or bleed. Also, some people add the letters F and G. F for firm, G for growing lesions. These are helpful to keep in mind for accurately diagnosing a clinically amelanotic or non-pigmented nodular melanoma. Two other helpful clinical clues are the Little Red Riding Hood sign, which represents the finding of erythema or inflammation that at times will surround a cutaneous melanoma. And the other is the ugly duckling sign, which focuses on the morphologic differences between a single striking lesion and the surrounding benign signature nevi. As we mentioned, a lot of people have moles that resemble each other, and if they have a mole that sticks out like a sore thumb, that mole should be checked. Here's an example of that. This patient has multiple nevi that all kind of look like each other, except for this one up here. This one stands out, and this is a closer view of that lesion, which was a superficial spreading melanoma. I like to use this kind of handout in my practice. This is a summary of the A, B, C, D, E of melanoma. A section here that instructs the patient how to check their moles themselves using a mirror and maybe a hand mirror as well. And then an area where the patient can mark places that they've found moles that they're concerned about. And then they can write the details of those and then bring this into clinic for me to examine. The back of the sheet is shown here, which just has reminders on how to protect yourself from the sun. Here are some clinical images. This is a long-standing superficial spreading melanoma. Look at the asymmetry. You definitely could not fold this in half and have it match on both sides. It has irregular borders, has variation in colors, scar-like regression zones, an inferior pink papule that indicates a vertical growth phase. This is a superficial spreading melanoma arising in a pre-existing nevus. Note the irregular outline and variable pigmentation. The central brown papule represents the pre-existing nevus, and both the superior irregular brown-black plaque and the inferior erythematous plaque represent the melanoma. Another image of a melanoma. Different colors, irregular border, not symmetrical. This is lentigo maligna melanoma. It's an asymmetric pigmented lesion on the earlobe with irregular borders and significant variation in pigmentation. And then the lower image is a larger triangular brown patch in which there are multiple dark brown, black, and blue-gray papules and plaques. This is a melanoma in situ on the dorsal foot of an 84-year-old man. The lesion is asymmetric and not well circumscribed. Then you can see the dermoscopic image on the lower right here. Shows asymmetry, variation in color, atypical pigment network, and irregular brown blotches. Here are some images of acral lentiginous melanoma. This irregularly pigmented lesion is on the plantar surface of the foot. And then there's this crusted pink nodule on the heel. A close-up picture of that as well. Melanoma of the nail matrix. The longitudinal pigmentation of the nail plate is non-homogeneous, both clinically and under the dermatoscope. Now, we talked about nail anatomy yesterday and about the nail matrix where the nail is formed, is under this proximal nail fold. So it would not do any good to biopsy this area of the lesion, as the lesion is actually back here. And as the nail grows out, it is being dragged, the pigmentation is being dragged out with the nail. So the important place to biopsy would be back here. This is amelanotic melanoma. The skin-colored to light pink nodule on the right scapula of a female patient is about 4 millimeters in diameter. By dermoscopy, some pigmented globules allow one to identify the tumor as a melanocytic lesion. Dotted, point, and linear irregular vessels are also suggestive of melanoma. So this just underscores the importance of dermoscopy for clinical examination. This melanoma in situ measured less than 3 millimeters in diameter. Small melanomas can be easily overlooked, especially if they are less heavily pigmented. This lesion was the ugly duckling or outlier among this patient's nevi. Dermoscopy also assists in making an earlier diagnosis. So this just shows that the A, B, C, D, E of melanoma are good things to look for, but melanoma doesn't always play by the rules. So if it doesn't follow the ABCDE, still need to use clinical judgment and the other strategies we discussed, such as the ugly duckling, to establish an early diagnosis. On history, patients may report a changing mole or a new pigmented lesion. On physical exam, I recommend a full skin exam and dermoscopic evaluation. For diagnostic testing, an excisional or complete biopsy may be performed via full thickness, elliptical, or punch technique, or with a deep shave or saucerization to the level of the deep reticular dermis. This is the biopsy technique that most U.S. dermatologists use. Superficial shave biopsies should be avoided in order to avoid histologic transection and the underestimation of tumor thickness. In other words, it's very important to know the depth of melanoma at the time of diagnosis. For this reason, it's extremely important not to cut through the pigmentation. So the biopsy needs to go deeper than the pigmentation or underneath the pigmentation. The specimen should be sent to a pathologist experienced in the diagnosis of melanocytic tumors, preferably a board-certified dermatopathologist. Treatment depends a lot on staging. Early stages, treatment involves surgical excision with clear margins, with possible sentinel lymph node biopsy, particularly for medium depth melanomas. And then adjuvant therapy, such as immunotherapy, targeted therapy for advanced stages. Follow-up, regular skin checks every 3 to 6 months. I recommend skin exams every 3 months for at least the first 2 years after diagnosis. Patient education on self-skin exam and sun protection is very important. Now let's talk about melasma, also known as cloasma when it occurs during pregnancy. Melasma is characterized by hyperpigmented patches, typically on the face due to increased melanin production. Etiology: hormonal changes such as pregnancy or oral contraceptives, and sun exposure, also genetic predisposition. At least 90% of patients are women, and there is an increased prevalence in individuals who are Hispanic or of Asian or African descent. The most common location is the face, followed by the forearms. Clinically, we see symmetrical hyperpigmented macules, usually on the cheeks, forehead, upper lip, and chin. In other words, sun-exposed areas. Here's a clinical image. Another one. Here's another view. Again, these are patches, so if you closed your eyes and ran your finger over the hyperpigmentation, you wouldn't feel it. Patients may report gradual onset of pigmentation, often exacerbated by sun exposure or hormonal changes. On exam, we see well-demarcated hyperpigmented patches in a symmetrical distribution. For treatment, sun protection involving a broad-spectrum sunscreen is extremely important. Other topical agents include hydroquinone, tretinoin, corticosteroids. Chemical peels can be used, or sometimes laser therapy with the right laser for the right patient. For follow-up, I recommend regular follow-up to monitor response to treatment and to continually emphasize sun protection. Now we'll move on to hypopigmented disorders. Vitiligo is an acquired depigmentation disorder characterized by the loss of melanocytes, which are the cells responsible for skin pigmentation. This leads to well-demarcated white patches on the skin. The exact mechanism is not fully understood, but it's believed to involve a combination of genetic, autoimmune, and environmental factors. The autoimmune hypothesis suggests that the body's immune system mistakenly targets and destroys melanocytes. The precise cause of vitiligo is unknown, but it's thought to be multifactorial, involving genetic predisposition, autoimmune processes, and possibly environmental triggers such as stress, skin trauma, or exposure to certain chemicals. Remember, vitiligo is one of the conditions that we can see the Kebner phenomenon. Risk factors, we mentioned family history of either vitiligo or other autoimmune conditions, personal history of autoimmune conditions, skin trauma or severe sunburn, and emotional stress. As we mentioned, it's depigmented, not just hypopigmented, white patches of skin that can appear anywhere on the body. It's usually symmetrical, and patches may be more noticeable in sun-exposed areas. These areas do not tan. Premature graying of the hair on the scalp, eyelashes, eyebrows, or beard, and mucosal involvement, such as inside the mouth or the genitalia, can be seen. Here's an example of vitiligo on the lips. And you can see the symmetry here in this patient with vitiligo. Here you can see clearly how the area is completely depigmented. This is a good example of how it can affect the hair, in this case the hair of the eyelashes. Vitiligo is usually a clinical diagnosis primarily based on physical exam. Skin biopsy is rarely needed, but if done, it would show an absence of melanocytes. Often we'll do blood tests to rule out associated autoimmune conditions such as thyroid function tests, especially if there are clinical signs to support it. For treatment, topical corticosteroids or calcineurin inhibitors are often used for localized vitiligo. And then recently, there has been a topical Janus kinase inhibitor called ruxolitinib, 1.5% cream, and that was recently FDA approved for the treatment of non-segmental vitiligo involving less than 10% of the body surface area in patients over 12 years old. So that's exciting. We haven't had a FDA approved medication for vitiligo prior to this. Phototherapy is another treatment, narrowband UVB or PUVA for extensive areas, and depigmentation therapy for widespread vitiligo. Surgical options such as skin grafting or melanocyte transplantation can be done, and camouflage makeup or self-tanning products for cosmetic purposes. For follow-up, I recommend regular monitoring for spread of depigmentation, assessment of treatment efficacy and side effects, and psychological support and counseling if needed. Albinism is a group of genetic disorders characterized by a deficiency in the production of melanin, the pigment responsible for the color of the skin, hair, and eyes. This results from mutations in genes involved in melanin synthesis, leading to hypopigmentation. The most common types include oculocutaneous albinism, or OCA, which affects the skin, hair, and eyes, and ocular albinism, or OA, which primarily affects the eyes with minimal to no changes in skin or hair pigmentation. Genetic inheritance is autosomal recessive for OCA and X-linked for OA. Clinical manifestations involve hypopigmented skin and hair, and there can be a pretty wide range from white to light brown. depending on the type of albinism. Light-colored eyes with potential vision problems, nystagmus or involuntary eye movements, sensitivity to light, and reduced visual acuity and strabismus. Here's a clinical image. Historical information may include family history of albinism or hypopigmentation, history of vision problems, and onset and degree of skin and hair hypopigmentation. On physical exam, inspect the skin, hair, and eye color. Also check the eyes for nystagmus, photophobia, and visual acuity. And then examination for signs of sun damage or skin cancers. Diagnostic testing, clinical diagnosis based on physical characteristics, genetic testing to identify specific mutations, and ophthalmologic evaluation to assess eye abnormalities. For treatment, there's currently no cure. Management focuses on symptom relief and prevention of complications. The use of sunscreen and protective clothing to prevent sunburn and skin cancer is very important, as well as regular skin exams for early detection of skin cancers. Visual aids and glasses to improve vision is helpful, as well as regular ophthalmologic care. For follow-up, recommend routine dermatologic and ophthalmologic evaluations, monitoring for skin cancer development, supportive care for visual impairments, and genetic counseling for affected families. Next, we'll talk about some common scaling disorders. Atopic dermatitis is a chronic inflammatory skin condition driven by a combination of genetic, immunological, and environmental factors. It's characterized by a defective skin barrier, leading to increased transepidermal water loss and susceptibility to irritants and allergens. This results in chronic inflammation and a cycle of itching and scratching. For etiology, the exact cause of atopic dermatitis is unknown, but it's believed to involve a complex interplay of genetic predisposition, immune system dysregulation, and environmental triggers. Mutations in the filaggrin gene, which is important for skin barrier function, are commonly associated with atopic dermatitis. So risk factors are family history, personal history of other conditions such as asthma and allergic rhinitis, or history of eczema, and environmental factors. Also, stress. Here you can see the common clinical manifestations. I think it's important to mention that the distribution varies by age. In infants, it affects the face and extensor surfaces, and then in older children and adults, it typically involves the flexural areas, such as the antecubital fossa and the popliteal fossae, and the neck. Here's an infant with atopic dermatitis, and then an older child showing the flexural involvement. Atopic dermatitis is frequently described as the itch that rashes. It's characterized by dry red skin that may have scales and/or crust. Often there's intense itchiness accompanied by the desire to scratch. It affects nearly 1 in 10 Americans of all ages and up to 1 in 5 children. An estimated 60% of people with this condition develop it in their first year of life, and 90% develop it by the age of 5. However, atopic dermatitis can begin during puberty or later. Here's another example of atopic dermatitis. On history, we want to discuss onset and duration of symptoms, family and personal history of atopic diseases, identification of potential triggers, and the impact on quality of life. On exam, inspect the skin for characteristic lesions, assessment of the distribution and severity of the lesions, and also evaluation for secondary infections like bacterial or viral infections on the skin. Diagnostic testing, clinical diagnosis um, is based on history and physical exam. Allergy testing can be done to identify potential triggers. And then skin biopsy is rarely needed for atypical cases. There's a lot of treatments for atopic dermatitis. It's wonderful. Emollients to maintain skin hydration, topical steroids to reduce inflammation, topical calcineurin inhibitors for sensitive areas. There's also crisaborole, which is a PDE4 inhibitor that's FDA approved for treatment of mild to moderate atopic dermatitis in patients 3 months of age or older. There's also that topical JAK inhibitor, ruxolitinib, which we talked about for vitiligo, is also FDA approved for short-term or non-continuous chronic treatment of mild to moderate atopic dermatitis in patients 12 years of age or older. The JAK inhibitors have a class-wide black box warning that should be reviewed and discussed with the patient. Antihistamines are used to control itching. Systemic therapies, such as oral steroids, but now there are these wonderful biologics that work well for severe cases. We also want to avoid known triggers and irritants. And for follow-up, regular monitoring of disease progression and treatment efficacy, education on skincare routines and trigger avoidance, and psychological support for patients and families. Lichen simplex chronicus is a chronic skin condition characterized by thickened lichenified plaques resulting from repetitive scratching or rubbing. It's often considered a secondary condition to an underlying pruritic disorder, such as atopic dermatitis, psoriasis, or even psychological stress. You can see those risk factors listed here. So again, the skin looks thickened and leathery where it's been scratched or rubbed. It can often be hyperpigmented or hypopigmented. And it itches. The more you scratch it, it seems like the more it itches. Common sites, the neck, scalp, ankles, wrists, and genital areas. Here's a nice netter drawing of Lichen simplex chronicus. Here you can see the lichenified pink plaque on the ankle of a young man. And then in the bottom picture, note the increased skin markings in this hyperpigmented plaque on the posterior neck. On history, we want to discuss the duration and intensity of itching, history of skin conditions or psychological stress, and triggers for scratching or rubbing. On exam, inspect the affected areas for lichenified plaques, assess the skin texture and pigmentation, and evaluate for signs of secondary infection. Anytime a patient's scratching a lot, there's a chance for secondary infection. Clinical diagnosis is based on characteristic appearance and history, and skin biopsy, if needed, can be done to rule out other conditions. The main goal of treatment is to stop the itching, to stop the scratching. Topical steroids are used to reduce inflammation and itching. Topical calcineurin inhibitors like tacrolimus or pimecrolimus are used for sensitive areas. Antihistamines can be used to control itching. Behavioral therapy can be used to break the itch-scratch cycle. Occlusive dressings can be put on the lesion to prevent scratching. And for follow-up, I recommend regular monitoring for treatment response and recurrence, patient education on trigger avoidance and skincare routines, and of course, psychological support if needed. Nummular eczema, also known as discoid eczema, is characterized by coin-shaped, itchy, and scaly plaques on the skin. The exact pathophysiology is not well understood, but it's thought to involve a combination of skin barrier dysfunction, environmental factors, and possibly microbial colonization. The cause is unknown, but it may be related to dry skin trauma, or an allergic response. Other risk factors: a history of atopic dermatitis or other eczematous conditions, cold weather, low humidity, and skin trauma or irritation. The word nummular means coin-shaped, and it's, of course, erythematous and scaly, patches or plaques, intense itching, commonly occurs on the extremities, but can really occur anywhere. And lesions may ooze or become crusted, particularly if they get infected. Here's an example of an infant with nummular dermatitis. Obtain a history of the onset and duration of lesions, history of similar episodes or atopic conditions such as asthma or allergic rhinitis. Exposure to potential irritants or allergens is also important. On exam, inspect the skin for characteristic nummular coin-shaped lesions and assess for signs of secondary infection. Diagnostic testing is often a clinical diagnosis based on appearance and history. Skin biopsy is rarely needed to confirm the diagnosis. Treatments: again, emollients to hydrate the skin, topical corticosteroids or calcineurin inhibitors to reduce inflammation, antibiotics if secondary infection is present, and avoidance of known irritants and allergens. For follow-up, regular monitoring for treatment response and recurrence is important. Education on skincare routines and trigger avoidance, and as always, psychological support if needed. Now we'll talk about psoriasis, which is a chronic immune-mediated inflammatory disorder characterized by hyperproliferation of keratinocytes and abnormal differentiation. It involves a complex interplay between genetic predisposition, immune system dysregulation, and environmental triggers. Approximately 7.5 million people in the United States have psoriasis. The exact cause is unknown, but it's believed to involve genetic susceptibility and environmental factors. Key players in the pathogenesis include T cells, dendritic cells, and inflammatory cytokines such as TNF-alpha, IL-17, and IL-23. It can run in families. There are environmental triggers such as infections, stress, and skin trauma. Certain medications can trigger it, such as beta blockers or lithium. Obesity and smoking or alcohol consumption are risk factors. Plaque psoriasis is classically described as erythematous plaques with silvery scales, often on the scalp, elbows, knees, and lower back. Nail changes, there are multiple nail changes. We'll look at those in a minute. Sometimes there's pruritus and discomfort. And then there's multiple variants: plaque psoriasis, guttate psoriasis, which is drop-like lesions, inverse psoriasis, usually in body folds, pustular psoriasis, and erythrodermic psoriasis. Here are a couple examples of plaque psoriasis: erythematous plaques with a silvery scale. Here's a more widespread distribution. Here you can see the thick plaques involving the elbows. And here it is involving the palms. Here we see nail plate pitting, distal onycholysis or lifting of the nail, is oil drop changes, and subungual under the nail, and proximal hyperkeratosis are seen. There's also proximal nail fold inflammation with loss of the cuticle. Auspitz's sign is when a psoriatic plaque is removed. It leaves behind this area of pinpoint bleeding. Helps to confirm the diagnosis of psoriasis. The Kebner phenomenon, also known as the isomorphic response, refers to the appearance of new skin lesions on previously unaffected skin following trauma or injury, such as a scratch, surgical wound, or sunburn, in patients with certain skin diseases. This phenomenon is most commonly associated with psoriasis, as pictured here, but can also occur in other conditions such as lichen planus and vitiligo. The new lesions typically have the same histopathological characteristics as the primary disease. Patients with psoriasis should be warned of this tendency before subjecting themselves to cosmetic procedures involving physical trauma, such as having a tattoo. On history, I like to ask onset and duration of symptoms, family history of psoriasis or other autoimmune diseases, identification of potential triggers, and impact on the patient's quality of life. I also think it's important to ask if there is any arthritis or any rash in the genital or groin area, as patients don't often volunteer that information. On physical exam, inspect the skin for characteristic plaques, inspect the nails for involvement, and also evaluate for signs of psoriatic arthritis, such as joint swelling. It's often a clinical diagnosis based on characteristic lesions. Skin biopsy, if needed, can confirm the diagnosis, and blood tests to rule out other conditions and to assess for comorbidities can be helpful. There are now excellent treatments for psoriasis. Treatments include topical therapies such as corticosteroids, vitamin D analogs, calcineurin inhibitors, and then the newer topicals, roflumilast and tapinarof. Phototherapy, such as narrowband UVB, and then PUVA. Systemic therapies, such as the new JAK inhibitors, there's apremilast, then older treatments such as methotrexate, cyclosporin, and acitretin. Biologic agents targeting specific immune pathways are frequently used now. There's TNF alpha inhibitors, and then IL-17 inhibitors and IL-23 inhibitors. Lifestyle modifications are important, such as weight loss and smoking cessation. Follow-up. Of course, we want regular monitoring for treatment efficacy and evaluation of potential side effects. Assessment for comorbid conditions such as cardiovascular disease or metabolic syndrome. And psychological support for patients and families. And then, last but not least, education on disease management and trigger avoidance. Now let's talk about pityriasis rosea. It's an acute, self-limiting skin condition that's believed to be of viral origin, possibly linked to human herpes virus 6 or 7. It's common in adolescents and young adults, with seasonal peaks in spring and fall. Clinically, we often see a herald patch, which is a single, large, pink scaly patch or plaque that appears first, followed by a generalized body rash. Secondary eruption of smaller, scaly, oval patches or plaques that involve the lines of skin cleavage in what some describe as a Christmas tree pattern. Here's an example. Another example here. This image clearly shows the herald patch along with the secondary lesions. Here's a closer view of a herald patch with multiple smaller lesions seen. History asks about a recent upper respiratory infection. Physical exam, look for the Herald patch along with a secondary eruption. This is often a clinical diagnosis. KOH prep can be used to rule out fungal infection, and serologic testing for syphilis if syphilis is suspected. I think it's important to bring up here that pityriasis rosea can look similar to secondary syphilis. One of the distinguishing characteristics is secondary syphilis often involves the palms and soles, and pityriasis rosea typically doesn't. It is important not to miss secondary syphilis, which is often described as the great imitator. They can look like a lot of other skin diseases. Treatment, so it's basically symptomatic treatment often with antihistamines and topical steroids to help with itching. Small amounts of sun exposure can help, and oral antiviral agents in severe cases. Follow-up, this condition is generally self-limiting in about 6 to 8 weeks. It is important to follow up to ensure resolution and to manage persistent symptoms. Seborrheic dermatitis and dandruff, a chronic inflammatory skin disorder affecting areas with high sebaceous gland activity, and overgrowth of Malassezia yeast is implicated. Also, genetic and environmental factors. Other risk factors, family history, neurological and psychiatric conditions such as Parkinson's disease or HIV is associated with worse seborrheic dermatitis. Dandruff looks like dry, flaky skin on the scalp. Seborrheic dermatitis is erythematous, greasy scales on the scalp, face, and other sebaceous areas. History and physical exam, we want to ask about the history of chronic relapsing course, and physical exam shows characteristic distribution and appearance of lesions. In infants, this is called cradle cap. Here's a nice drawing showing typical presentation, and then clinical images showing that seborrheic distribution around the creases of the nose, the hairline, behind the ear, areas where there's a lot of sebaceous glands. This is often a clinical diagnosis. Skin biopsy can be used in uncertain cases. Treatments with antifungal shampoos like ketoconazole, sometimes with topical steroids or calcineurin inhibitors. Regular follow-ups important to manage recurrences, and long-term maintenance therapy is often required as this is a condition that tends to come and go. Now let's talk about some superficial fungal infections. Tinea corporis is a dermatophyte or superficial fungal infection of the body's skin. Etiology, trichophyton, microsporum, and epidermophyton species can be involved. Risk factors, warm, humid environments, contact with infected individuals or animals, although sometimes it's just transmitted through the environment. Clinical manifestations include annular, scaly plaques with central clearing. History, you want to ask about history of exposure to affected individuals or animals. And then physical exam reveals the characteristic annular ring-shaped lesions. We often say they can have a raised serpiginous or snake-like border. Diagnostic testing, we talked about the KOH prep yesterday. That's a nice test that can be done in the office. Fungal culture can also be obtained and sent to the lab for species identification. We treat this often with topical antifungals such as terbinafine, clotrimazole, ketoconazole. There's several. Oral antifungals can be used for extensive cases. Follow-up, we recommend follow-up to ensure resolution, and we educate the patient on hygiene to prevent recurrence. Tinea cruris is a dermatophyte infection of the groin area, often caused by Trichophyton rubrum. Risk factors include obesity, tight clothing, and excessive sweating. It looks like erythematous scaly patches or plaques in the groin area with that raised serpiginous border often. History, when I ask about itching and discomfort in the groin area, physical exam shows these well demarcated scaly plaques. Diagnostic testing, we talked about KOH prep previously. That's a nice test that can be done at the bedside or in the office. Fungal culture can also be obtained for species identification. That's sent to the lab. Treatment is with topical antifungals and oral antifungals if severe. Follow-up to ensure complete resolution and address the predisposing factors. Tinea manum, referring to hand, and pedis, referring to feet, obviously are dermatophyte infections of the hands and feet, usually caused by the Trichophyton species. Risk factors include moist environments, communal showers. On exam, we see scaling, fissuring, and maceration of the skin. On history, we ask about excessive sweating or exposure. Physical exam shows characteristic scaling and fissuring. Diagnostic tests, again, we can do KOH prep or fungal culture or both. Treatment, topical antifungals and oral antifungals if needed for chronic cases. Follow-up to ensure resolution and educate the patient on preventative measures for recurrence. Tinea versicolor, also called pityriasis versicolor, is a superficial fungal infection caused by Malassezia species. It's considered to be an overgrowth of skin commensal yeast. Risk factors are hot, humid climates and oily skin. Often we see hypo or hyperpigmented macules or patches or thin papules on the trunk and extremities. Historical and physical exam, history of recurrent episodes, and physical exam shows the characteristic lesions. Diagnostic testing, Wood's lamp can be used. KOH prep. With KOH prep, we see that classic spaghetti and meatballs appearance. We showed that in the previous lecture. Treatment is with topical antifungals such as selenium sulfide or ketoconazole, and oral antifungals if extensive or severe. Follow-up is recommended to ensure resolution, and then maintenance therapy is recommended to prevent recurrence. This also is a condition that often comes and goes. Now let's talk about discoid lupus erythematosus and subacute cutaneous lupus erythematosus, or SCLE. These are autoimmune skin disorders with varying degrees of systemic involvement. There's a genetic predisposition, and then also ultraviolet light exposure is a risk factor. Clinical manifestations for discoid lupus, we see erythematous scaly plaques with scarring. With SCLE, we see annular polycyclic erythematous scaly plaques. On history, you can ask about a history of photosensitivity or history of lupus or similar skin lesions. Physical exam shows the characteristic lesions. Diagnostic testing, often order an ANA. And for SCLE, suspected, we order anti-Rho or SSA and anti-La or SSB antibodies. Skin biopsy is also helpful. Treatment with topical steroids and calcineurin inhibitors. Systemic antimalarials like hydroxychloroquine can also be used. Follow-up, recommend regular follow-up for monitoring, and then educate the patient on sunscreen and photoprotection. This slide shows various presentations of discoid lupus erythematosus. In these slides, we see lesions which favor the head and neck region that show erythema, scaling, atrophy, and dyspigmentation, in addition to scarring and alopecia. In this slide, we see these follicular openings, in addition to hyperpigmentation and scale. In these slides here, we see well demarcated in both hypopigmentation and scarring. This slide shows SCLE. Lesions are most commonly seen on the upper trunk and sun-exposed aspects of the upper extremities. The margins of the annular lesions may have scale and crust, or may be composed of multiple papules, like in this slide. Note the peripheral scale and relative sparing of the proximal interphalangeal joints. And then in this slide, there's numerous annular lesions with scale crust in the inner borders with a patient with terbinafine-induced SCLE. For history, we want to discuss a history of photosensitivity. Physical exam shows characteristic lesions. Diagnostic testing, we often order ANA. Also for SCLE, it's helpful to order anti-Rho or SSA or anti-La or SSB antibodies. Skin biopsy is also helpful. Treatment, topical steroids and calcineurin inhibitors. Also, systemic antimalarials like hydroxychloroquine can be used. Follow-up, regular follow-up for monitoring is important, and then educate the patient about sunscreen and photoprotection. Now let's talk about cutaneous T-cell lymphoma, or mycosis fungoides. This is a rare malignancy of T lymphocytes affecting the skin. Etiology is unknown, possibly genetic and environmental influences. Risk factors, middle-aged to older adults, and male gender. Common clinical manifestations, patches, plaques, tumors, or erythroderma. This slide shows the patch and plaque stage on the left, and then tumor stage on the right. For history, you want to ask about chronic progressive skin changes. Physical exam shows various stages of lesions. Diagnostic testing, skin biopsy is helpful, although sometimes it does require multiple biopsies over time to get this diagnosis. And immunophenotyping is helpful. Treatment with topical steroids and phototherapy, and there are systemic therapies for advanced stages. Follow-up is very important to monitor progression, and a multidisciplinary approach is important. I like to involve an oncologist with this. Now let's talk about exfoliative dermatitis or erythroderma. This is widespread erythema and scaling of the skin involving over 80% of the body's surface area. Erythroderma has multiple etiologies. In adults, the most common causes are psoriasis, drug reactions, atopic dermatitis, and cutaneous T-cell lymphoma. Risk factors, a pre-existing dermatitis, or drug reaction. Common clinical manifestations, generalized erythema and scaling. This shows obvious exfoliation of scale with underlying erythema. This is a slide of psoriatic erythroderma. There's diffuse involvement of the trunk, but a clue to the diagnosis is the individual lesions on the arm. And then there's significant exfoliation of the lateral trunk and arms. For history, you want to obtain a history of medication exposure or underlying skin condition. Physical exam shows extensive skin involvement. This is often a clinical diagnosis, but skin biopsy can be performed if needed. Treatment, most important thing is to identify and treat the underlying cause, and then supportive care, emollients, and systemic steroids. Regular follow-up is extremely important to monitor improvement, and then it's very important to discuss with the patient the need to address the underlying condition. Next, let's talk about actinic keratosis. Actinic keratosis is a precancerous skin lesion caused by ultraviolet damage. Now, we call it precancerous because if left untreated, a small percentage of actinic keratoses may progress to squamous cell carcinoma. Risk factors: fair skin, excessive sun exposure, chronic sun exposure, and things like outdoor occupation. Clinical manifestations: these are rough, scaly, thin papules or plaques on sun-exposed areas. Here are several examples of actinic keratoses. You can see some more hyperkeratotic or thicker ones here, and then some thinner ones up here. History and physical exam. Ask about a history of sun exposure. Physical exam shows the characteristic skin lesions. This is often a clinical diagnosis. However, biopsy is very important if there is any suspicion for squamous cell carcinoma. Treatment often involves cryotherapy with liquid nitrogen. There are several topical agents such as 5-fluorouracil, imiquimod, and terbinafulin is a more recent one. Photodynamic therapy, or PDT, is another effective treatment for actinic keratoses. It involves the application of a photosensitizing agent called aminolevulinic acid, or ALA, followed by exposure to a specific wavelength of light, which activates the agent and destroys the abnormal cells. The benefits are that it's non-invasive, it's a non-surgical treatment option, it's targeted, it selectively targets the abnormal cells while sparing healthy tissue, and the cosmetic outcomes. It generally results in good cosmetic outcomes with minimal scarring. Follow-up for actinic keratoses involves regular follow-up for new lesions, and sun protection education is very important. Now let's talk about Bowen's disease. Bowen's disease is squamous cell carcinoma in situ. In situ meaning the cancer cells are confined to the epidermis and have not invaded the deeper layers of the skin. Etiology: a main one is chronic sun exposure. Sometimes also human papillomavirus or HPV infection, or immunosuppression, or exposure to arsenic. This is usually from well water. Risk factors include fair skin, older age, chronic sun exposure, immunosuppression, or history of other skin cancers. Common clinical manifestations: slowly enlarging, well-demarcated, scaly erythematous plaques. Lesions may be single or multiple, and they're usually found on sun-exposed areas like the face, neck, and hands. Here's an example of Bowen's disease. And another example here. History, ask about history of prolonged sun exposure or possible history of HPV infection or immunosuppression. On exam, we see erythematous scaly plaques with well-defined borders. They may have surface crusting or ulceration. Diagnostic testing, skin biopsy is important to confirm diagnosis and also to rule out invasive squamous cell carcinoma. Treatment options usually involve surgical excision. Sometimes curettage and electrodesiccation can be used. And although not FDA cleared for this indication, imiquimod 5% cream has shown some efficacy for cases when the patient is not a surgical candidate. Follow-up, regular skin checks to monitor for recurrence or new lesions, and patient education on sun protection is important. Now let's talk about extramammary Paget disease, or EMPD. This is an intraepithelial adenocarcinoma, often arising in areas rich in apocrine glands, like the genitalia, perineum, and axilla. Etiology. Primary EMPD originates from the epidermis, and then there's secondary EMPD, which is associated with underlying malignancy, such as colorectal, bladder, or prostate cancer. Risk factors: older age, female gender, although it can affect males as well. Common clinical manifestations: pruritic, erythematous, eczematous plaques, may have oozing, crusting, or ulceration. It commonly involves the genital or perianal regions. Here we see an erythematous plaque with hydrated scale at the base of the scrotum and well-demarcated perianal plaque with both erosions and scale. Over here we see extensive, well-demarcated disease of the vulva with multiple foci of hydrated white scale. History, ask about persistent non-healing eczematous lesions in the anogenital area. Ask about pruritus and discomfort. Physical exam, the red velvety plaques with possible scaling and crusting. It may resemble eczema or dermatitis, but does not respond to typical treatments. Diagnostic testing, skin biopsy with immunohistochemical staining to confirm diagnosis. Treatment, wide local excision with clear margins, Mohs surgery for tissue conservation, radiotherapy for non-surgical candidates. Follow-up, regular follow-up is important to monitor for recurrence. Screening for underlying malignancies is extremely important if secondary EMPD is suspected. Next, we'll talk about intertrigo. Intertrigo is inflammation of skin folds due to friction, moisture, and heat, leading to maceration and secondary infection. Etiology, Candida species. Also, bacterial infections, such as Corynebacterium and Staphylococcus aureus. Risk factors include obesity, diabetes, hyperhidrosis, and poor hygiene. Common clinical manifestations: erythematous, macerated plaques in the skin folds, such as under the breasts, groin, and armpits. There's often itching, burning, and discomfort, and possible secondary infection with odor or discharge. Clinical image of intertrigo, and another typical presentation of intertrigo. On history, symptoms are exacerbated by heat and sweating, and the patient reports recurrent episodes in the skin folds. Physical exam, erythema, maceration, and possible fissuring in the skin folds, and satellite pustules if Candida infection is present. This is often a clinical diagnosis. KOH prep or fungal culture can be used to identify Candida. Bacteria culture can be used to identify bacteria. especially if secondary infection is suspected. Treatment, you want to keep the areas dry and clean. Use of barrier creams or powders can be helpful. Topical antifungals such as clotrimazole, miconazole, ketoconazole, cyclopirox are helpful. Topical steroids can be used as necessary for inflammation, along with the topical antifungal. Follow-up, you want to monitor for recurrence and address the underlying risk factors such as weight management and diabetes control. Erythrasma is a superficial bacterial infection caused by Corynebacterium minutissimum. Corynebacterium minutissimum thrives in warm, moist areas of the skin. Risk factors are obesity, diabetes, hyperhidrosis, and poor hygiene. Common clinical manifestations: well-demarcated brownish-red patches in intertriginous areas, such as groin, armpits, and between the toes. It's often mild scaling and itching. Here's a clinical image of erythrasma. For history, we want to ask about chronic recurrent skin discoloration and skin folds with minimal discomfort. On physical exam, we see the brownish red scaly plaques in intertriginous areas. And with the Woods lamp, there's a characteristic coral red fluorescence seen, and that's pictured here. Other diagnostic testing can include bacterial culture or skin biopsy if diagnosis is uncertain. Treatment is with topical or oral antibiotics such as clindamycin or erythromycin, antibacterial soaps, and keeping the affected areas dry and clean. Follow-up, we want to monitor for recurrence and address the underlying risk factors. Now let's talk about dermatitis medicamentosa, or drug-induced dermatitis. This is a hypersensitivity reaction to a medication leading to skin inflammation. Any drug can potentially cause this. Common culprits include antibiotics, NSAIDs, and anticonvulsants. Risk factors include a history of drug allergies, polypharmacy, or genetic predisposition. Common clinical manifestations show a widespread erythematous rash, often morbilliform or maculopapular. There's often pruritus and discomfort. Sometimes there's fever and systemic symptoms in severe cases, such as with DRESS syndrome, which stands for drug reaction with eosinophilia and systemic symptoms. Here are several clinical images of drug-induced dermatitis. Ask about recent initiation of a new medication and previous medication reactions and allergies. On physical exam, there's often a diffuse erythematous rash, often symmetrical, with possible involvement of mucous membranes. This is frequently a clinical diagnosis based on history and physical exam. Skin biopsy can be helpful in uncertain cases. Treatment number 1 is discontinuation of the offending drug. Also, symptomatic treatment with antihistamines and topical steroids, and then systemic steroids for severe reactions. Follow-up is important to monitor improvement. Patient education is important to discuss avoidance of the offending drug and related compounds. Also, patient education on drug allergies and the importance of medical alert identification. Next, we'll talk about some vesicular dermatoses. Herpes simplex virus, or HSV, infects epithelial cells and establishes latency in the sensory ganglia. Reactivation leads to recurrent lesions. Etiology, this is caused by HSV type 1 and HSV type 2. HSV 1 typically affects the orofacial region, while HSV 2 usually affects the genital region. However, this is not always the case. Risk factors: close contact with infected individuals, immunosuppression, stress and fatigue, and ultraviolet light or sun exposure. Common clinical manifestations. These are painful vesicular eruptions on an erythematous base, prodromal symptoms like tingling, itching, or burning. Vesicles can rupture, forming ulcers that crust over. So here we see the classic grouped vesicles on an erythematous base. Here is a more extensive involvement of the orofacial area involving pustules. Patients often report recurrent episodes with a history of similar lesions in the past. Triggers such as stress, illness, or sun exposure may be noted. On exam, we see grouped vesicles on an erythematous base, which may progress to pustules and ulcers. Diagnostic testing: viral culture or PCR from skin lesion swabs. You can also do direct fluorescent antibody or DFA testing and serologic testing for HSV antibodies. Treatment is antiviral medications such as acyclovir, valacyclovir, or famciclovir, topical antivirals for mild cases, and pain management with analgesics. Follow-up is important to monitor for recurrence and to manage with suppressive antiviral therapy if frequent outbreaks occur. Educate patients on avoiding triggers and reducing transmission risk. Next, we'll talk about herpes zoster or shingles, which is reactivation of the varicella zoster virus, or VZV, from the dorsal root ganglia, leading to a localized unilateral vesicular rash. VZV, as a reminder, is the virus that causes chickenpox. Risk factors are advanced age, immunosuppression, stress, and trauma. Clinical manifestations: painful unilateral vesicular rash in a dermatomal distribution, prodromal pain, itching or tingling, and postherpetic neuralgia, which is persistent pain after the rash resolves. Here we see a classic example of herpes zoster following a dermatome. A dermatome is an area of skin that is mainly supplied by a single spinal or cranial nerve. This dermatome shows the trigeminal nerve being involved. Ask about history of chickenpox or exposure to varicella zoster virus. Patients report severe pain prior to rash appearance frequently. On exam, see unilateral dermatomal vesicular eruption on an erythematous base, which may progress to pustules and crusts. Diagnostic testing: this is often a clinical diagnosis based on appearance, but PCR or direct fluorescent antibody or DFA testing from lesion swabs can be obtained, or a zinc smear, as we discussed in our previous lecture. Treatment is with antiviral therapy such as acyclovir, valacyclovir, or famciclovir, ideally within 72 hours of rash onset. Pain management with analgesics, anticonvulsants, or tricyclic antidepressants. Also, corticosteroids can be used in severe cases. Follow-up: it's important to monitor for complications such as postherpetic neuralgia. Next, we'll talk about dyshidrosis or vesiculobullous hand eczema. The exact cause is unknown, but it may involve sweat gland dysfunction, hypersensitivity reactions, or stress. The etiology is multifactorial including genetic predisposition, environmental triggers, and stress. Risk factors include atopic dermatitis, allergies, stress and sweating, and exposure to irritants. Common clinical manifestations: intensely pruritic, deep-seated vesicles on palms, sides of fingers, and soles. Vesicles may coalesce and form bullae. Chronic cases may result in fissuring and lichenification. Here is a clinical image. There is some fissuring. Patients often report recurrent episodes, particularly in warm weather or during periods of stress. On exam, we see small, deep-seated vesicles on the palms, fingers, and/or soles. Chronic cases may show scaling and fissures. This is often a clinical diagnosis based on appearance. Patch testing may be performed to identify potential allergens, and skin biopsy is recommended in atypical cases. Treatment with topical corticosteroids, also emollients to maintain skin hydration, and avoidance of triggers and irritants. Antihistamines can be used for pruritus. Follow-up: recommend regular monitoring to assess response to treatment and adjust therapy as needed. Patient education involves trigger avoidance and skin care. Next, we'll talk about porphyria cutanea tarda. This is a deficiency of uroporphyrinogen decarboxylase, or UroD, leading to accumulation of porphyrins in the skin, causing photosensitivity. Etiology: this can be sporadic or inherited. Triggers include alcohol, estrogens, iron overload, and hepatitis C, with risk factors being genetic predisposition, alcohol use, hepatitis C infection, and iron overload, such as from hemochromatosis. Common clinical manifestations: the disease is characterized by photosensitivity, resulting in skin fragility and bullae, especially in sun-exposed parts. The dorsal hands and forearms, ears, and face are primarily affected. The bullae are non-inflammatory and rupture easily to form erosions or shallow ulcers. These heal with scarring, milia, and dyspigmentation. Lesions on the legs, especially the shins and dorsal feet, occur primarily in women. There is hyperpigmentation of the skin, especially of the face, neck, and hands. Hypertrichosis of the face, especially over the cheeks and temples, can occur. The face and neck, especially in the periorbital area, may show a pink to violaceous tint. Sclerodermatous thickenings may develop on the back of the neck, in the preauricular areas, or on the thorax, fingers, and the scalp, with associated alopecia. So these are typical findings on the hands. Here you can see the sclerodermoid changes in porphyria cutanea tarda. These are some classic changes of PCT found in a patient with hemochromatosis. Patients often report blistering and skin fragility upon sun exposure. History of alcohol use or liver disease may be present. On exam, as we mentioned, blisters, erosions, and scars on sun-exposed areas are common. Hyperpigmentation and hypertrichosis may be seen. For diagnostic testing, we recommend measurement of urine, plasma, and stool porphyrins. Serum iron studies and liver function tests, and genetic testing for familial cases. Treatments include phlebotomy to reduce iron stores, low-dose hydroxychloroquine, avoidance of alcohol and estrogen, and sun protective measures. Follow-up is important for regular monitoring of porphyrin levels and liver function, with adjustments to treatment based on response and management of any underlying conditions. Patient education includes sun protection and avoidance of triggers. Understanding the timing of onset and presentation of common dermatological conditions across different life stages can be helpful for diagnosis and treatment. Here's a sample of a few conditions seen at different life stages. For infants, we have diaper dermatitis, usually within the first few weeks to months of life. The red inflamed skin in the diaper area. Here's a classic example of that. Also, atopic dermatitis, we've already talked about, usually appears between 2 to 6 months of age in infants, and we see the erythematous scaly patches or plaques on the cheeks, scalp, and extensor surfaces for infants. And this is an example. There may be some secondary bacterial infection there. Next is infantile hemangiomas, usually noticed within the first few weeks after birth, and they can be different colors, they can be superficial or deep. And here's a good example of that. Children, atopic dermatitis can still be from infancy or can develop between ages 2 to 5. With atopic dermatitis, we see the eczematous lesions in the flexural areas, like the antecubital fossa and the popliteal fossa. Another common condition in children is molluscum contagiosum, commonly seen in preschool and school-age children, and they're small, skin-colored or pink, dome-shaped umbilical papules, we call it because it has that central dimple. Tinea capitis is another condition typically occurring in school-age children with scaly, itchy patches or plaques on the scalp, sometimes with hair loss. Clinical presentations of tinea capitis due to trichophyton tonsurans can range from mild scalp scaling, like this picture, to patchy alopecia with black dots, or scale, to large areas of alopecia with pustules and scale crust. Then these are called carry-on formation due to T. tonsurans. Common conditions for adolescents include acne vulgaris, which usually begins around puberty, with open and closed comedones, papules, pustules, sometimes nodules and cysts, usually on the face, chest, back, and shoulders. Seborrheic dermatitis can start in adolescence, can persist into adulthood, and we talked about the greasy scales with erythematous patches or plaques, usually on the scalp, face, or upper trunk, areas where there's a lot of sebaceous glands. Psoriasis can begin in late childhood or adolescence, and with the well-demarcated erythematous plaques with silvery scales, often elbows, knees, scalp, lower back. Common conditions that occur in adults include rosacea, which typically starts in the 30s to 50s with facial erythema, telangiectasia, papules, pustules on the central face. We talked about avoidance of triggers such as sunlight, spicy foods, alcohol, and coffee. Melasma occurs mostly in women during reproductive years with hyperpigmented patches on the face, usually on the cheeks, bridge of the nose, forehead, and upper lip. And then contact dermatitis can occur at any age, but most common in adulthood, often from exposures at work, with erythematous, itchy, scaly plaques at the site of contact with allergens or irritants. Common dermatologic conditions in the elderly include actinic keratosis, which commonly presents after the age of 60, with the rough, scaly patches, papules, or plaques on sun-exposed areas like the face, ears, neck, and hands, also bald scalp. Seborrheic keratoses often occur in middle-aged to elderly individuals, although it can happen in anyone typically over the age of 30, with the waxy, wart-like growths that are tan, brown, or black. And then bullous pemphigoid typically occurs in individuals over 60 with large, tense blisters, vesicles, or bullae on normal or erythematous skin, usually on the lower abdomen, groin, and limbs. I'll show you an image of bullous pemphigoid. Tense vesicles and bullae vary in size from a few millimeters to several centimeters in diameter and can arise within normal appearing skin, areas of erythema, or urticarial plaques. The blister fluid may be serous or hemorrhagic. The flexor aspect of the extremities is a common site of involvement. As the bullae age, they become flaccid and rupture, leaving erosions and serous or hemorrhagic crusts. Biopsies of vesiculobullae for routine histology should be obtained from the edge of a fresh, tense blister. Okay, now we're going to do a clinical scenario. So this is a 45-year-old woman who presents with a 6-month history of an itchy red rash on her elbows, knees, and lower back. The rash has a well-defined, raised, silvery scales. She reports that the lesions worsen during periods of stress and improve with sun exposure. She has a family history of similar skin conditions, and her medical history includes hypertension, managed with lisinopril, and a history of mild depression. Here's the clinical image, and you can see the erythematous plaques with silvery scale. So I think you already have what's at the top of your differential diagnosis, but it's important to have a complete differential to think of all possibilities. So differential diagnosis, psoriasis, of course, is the most likely diagnosis. Could think about seborrheic dermatitis, although it's not a typical location for it, and they're not the greasy scale. Lichen planus is a good consideration here. Atopic dermatitis could be a chronic atopic dermatitis, or tinea corporis. If the diagnosis were in question, we would want to do a skin biopsy to confirm the diagnosis histologically. In this case, based on the history and physical exam findings, we're confident in our clinical diagnosis of psoriasis. So now let's talk about acute and chronic patient-centered treatment. For acute treatment, we could consider topical corticosteroids, particularly high-potency steroids like clobetasol for short-term use on thick plaques, and topical vitamin D analogs such as calcipotriene, which can help reduce scaling and inflammation. Phototherapy, particularly narrowband UVB phototherapy, is effective, particularly given that the patient reported improvement with sun exposure. If the psoriasis is more moderate or severe, we could consider one of the many systemic treatments we discussed earlier, such as an oral apremilast or JAK inhibitor, or a biologic injection such as a TNF inhibitor, IL-17 inhibitor, or IL-23 inhibitor. We should also discuss with the patient lifestyle modifications, like stress management techniques, dietary adjustments, and regular skincare routines. And then we should emphasize regular follow-up, scheduling follow-up visits every 3 to 6 months to monitor treatment efficacy and side effects. We could discuss with the patient a possible referral to a psychologist or psychiatrist for management of depression and stress, based on her history, which are exacerbating factors for psoriasis. Also, if there are any signs of psoriatic arthritis, we could refer the patient to a rheumatologist. And if needed, we could refer the patient to a nutritionist to help with dietary modifications that may reduce inflammation. And then we'll counsel the patient based on genetic and psychosocial factors, discussing the genetic predisposition to psoriasis and the potential for familial occurrence, and educate the patient about potential triggers such as stress, infections, and skin injuries, and how to manage them. We should also consider psychosocial factors like mental health support, given her history of depression, to ensure she has access to mental health resources. And support groups. Encourage participation in support groups for individuals with psoriasis to share experiences and coping strategies. It's important to consider factors affecting patient adherence to care plans, such as complexity of treatment regimen. If possible, simplify the treatment regimen and provide clear instructions to the patient. Side effects. Monitor and manage any side effects to ensure patient comfort and adherence. Cost of medications. It helps to discuss cost-effective treatment options or assistant programs if necessary. And then patient education, ensuring the patient understands the importance of adherence and the potential consequences of non-adherence. Patient education strategies. We can provide brochures, websites, and other resources about psoriasis. Demonstrations. We can show the patient how to apply topical medications correctly. If we're going to do a biologic injection, we can teach the patient how to do the injections correctly. Lifestyle advice. Offer advice on stress management, healthy diet, and skincare routines. Family involvement. Educate family members to help them understand the condition and support the patient. And then regular check-ins. We'll schedule regular follow-ups to address any concerns and adjust treatment as needed. Here's an example patient education plan. On the initial visit, we'll explain psoriasis, its chronic nature, and the role of genetic and environmental factors. Then we'll outline the treatment plan, including the use of topical treatments, phototherapy, and potential systemic medications. We'll schedule a 1-month follow-up visit, and during that appointment, we'll check how well the patient is following the treatment regimen. We'll also discuss any side effects or difficulties the patient is experiencing. And then we'll provide additional educational materials and answer any questions. At subsequent visits every 3 to 6 months, we can monitor progress, evaluating the effectiveness of the treatment and making necessary adjustments. And we'll continue providing emotional and psychological support, including referrals to mental health professionals if needed and wanted by the patient. By integrating these approaches, we ensure comprehensive, patient-centered care that addresses both the clinical and psychosocial aspects of managing psoriasis. Today we covered common skin diseases and explored their clinical presentations, diagnostic criteria, and management strategies. We determined the typical timing of onset and presentation of common dermatological conditions across the lifespan, and integrated information given a clinical scenario related to a dermatological disorder. Understanding these conditions is crucial, as skin diseases are often the first sign of systemic issues and can significantly impact a patient's quality of life. As future PAs, your role in early detection and management is vital. Dermatology is a field that's constantly evolving with new research and treatments. I encourage you to keep up to date with the latest developments and continue learning throughout your careers. Remember the practical tips we discussed today. Always take a thorough patient history, perform comprehensive skin exams, and don't hesitate to refer to a specialist when necessary. Your work will make a significant difference in your patients' lives. Every time you help someone manage a chronic skin condition or identify a serious skin issue early, You're making a profound impact. Thank you for your attention to this presentation. Let me know if you have any questions about the things I discussed here or just questions about dermatology in general. I wish you all the best in your studies and future careers. Remember, the skin is not just a barrier, it's a window to overall health.